In today's video, we are going to discuss regarding movement disorders. Mainly, this is the chapter summary of 428 from Harrison, and I will try to cover the approach to movement disorders as well. First of all, what are movement disorders? So these are considered as involuntary movements which should not be accompanied by weakness. When there is associated weakness, we cannot consider it as a movement disorder. This is the first thing. Then these movement disorders can be hypokinetic or hyperkinetic. Usually in hypokinetic, in which we will notice slowness of movements, and the typical example is Parkinson's disease. But here the point to remember is one of the key feature of Parkinson's disease, that is tremor, is a type of hyperkinetic movement which is operating within the system of hypokinetic Parkinson's disease. So this is a kind of exception we have to remember. Similarly, when it comes to hyperkinetic disorders, we have several examples like Dystonia, we have Chorea, athetosis, Tics, Ballism, even myoclonic movements, Myoclonus. So these are some examples for hyperkinetic movement disorders. But again, when it comes to dystonia, which is categorized as hyperkinetic disorder, but here we will be able to see the typical feature of sustained muscle contractures, which practically appear as if the patient is hypokinetic. So there will not be any fast component in dystonias. Instead, there will be sustained contraction of the muscles, which might appear as a hypokinetic movement. Again, this is considered as an exception. Before going in detail regarding each of these hyperkinetic disorders, we will see how they will appear. So you might be knowing regarding tremors. So usually this type of picture you might have seen, and here we can see the sustained contraction at cervical musculature as well as in the upper limb. So this is what? This is dystonia. Whereas this sudden flinging type of movement of proximal segment of the limbs is Ballism. And these purposeless dance-like movements which we are seeing here are called as Chorea. Whereas these slow writhing movements of mainly digits, fingers, we call it as athetosis. And these twitching kind of movements are considered as tics. Whereas these sudden jerks of limbs is considered as Myoclonus. So these pictures you have to understand. And whenever we discuss a particular part in the further slides, we have to recall these images. And just to remember what we used to consider these three particularly hyperkinetic movements, just a simple analogy. Ballism is almost similar to the Arabic dance, like the belly dance you might be knowing, where there will be sudden flinging movements of the proximal segments of limb will be seen. Whereas Chorea is like a break dance, which if you imagine, you can easily correlate. And when it comes to athetosis, it is like our Bharatanatyam dance, where there will be slow writhing movements of the hands mainly. Just an analogy to remember. Now we will see how to approach when a patient presents with involuntary movements which are not accompanied by weakness. So that should be ruled out first. That is, evaluate for any weakness first. If it is not there, we will consider it as a movement disorder. So how to approach? For this one, I want to just give you a simple idea which you might be knowing when we discuss regarding the ECG interpretation. That is rate, rhythm, axis. These things we will be seeing when we are interpreting an ECG. Same things should be applied when we are approaching a case of movement disorder. So when it comes to rate, first decide whether it is a fast type or slow type. That is hypokinetic or hyperkinetic. So hypokinetic, typically we have the example of Parkinson's disease, which we will discuss in some other lecture in detail. Whereas when the rate appears to be fast type, it is hyperkinetic, and the examples we know. There are numerous examples. Then focus upon the rhythm, whether the rhythm is regular or not. That is, these hyperkinetic movements are rhythmic or not. So one of the example for rhythmic movements are tremors, whereas other hyperkinetic movements are considered as not rhythmic. So that's what we are seeing in the flowchart. Particularly when it comes to hyperkinetic spectrum, decide whether it is rhythmic or not. If it is rhythmic, the example is tremors. If it is not rhythmic, then what we have to do? Focus upon the axis. What does the axis mean here? Whether the movement is in single axis. For example, in dystonia, as mentioned, there will be sustained contraction of a particular group of muscles. So we can consider it as a single axis. So if it is following the axis, it might be probably dystonia, that is sustained contraction. If the movements are in various axes, then we have to consider the possibility of chorea, Ballism, Tics or Myoclonus. Then to differentiate further, what we have to do? Again, we have to follow few of the terminologies, like after rate rhythm axis, just remember repeat yes, yes. So what does it mean? When you have seen that the movements are in multiple axes, then you just focus whether these movements are repetitive in nature or not. For example, you have seen these movements in a patient, then you will call your friend and you will try to tell that just focus this patient, you will see this particular type of movement. Whatever you have observed, similar type will be repeated or not. That should be the thing to focus. So if it is a repetitive type of movement, it will be either tics or tremors. If it is non-repetitive, that is, you have seen certain type of movements, but when you want to show the same thing to your friend, the movements are not exactly repetitive. So in that case, we have to consider chorea, Ballismus or athetosis, even Myoclonus as the possibilities. After focusing upon the repetitive movements, then the yes term, what does it mean? Yes stands for suppressibility. So it means whether we are able to voluntarily suppress that movement or not. So what are the hyperkinetic movements which can be suppressed voluntarily? Mainly tics and dystonia can also be suppressed to some extent voluntarily, whereas others like tremors, chorea, Ballism or Myoclonus cannot be suppressed voluntarily. This is the next differentiating point. Then last S stands for the site. So which site is getting affected? For example, commonly when it comes to tics, it will be face which is commonly involved. When it comes to tremors, it will be fingers, and chorea will be involving limbs. Usually both proximal and distal segments will be involved. And athetosis, as I mentioned, mainly the fingers, distal segment will be involved, whereas Ballism will involve the proximal segment of limbs. And Myoclonus, again, it will be involving limbs. So based on site also, we will get some clue regarding the movement disorder. So whenever we are approaching the case, we have to remember these terminologies. Just recall about the ECG. Same thing should be followed. Rate, rhythm, axis, repeat, yes, yes. That's what is summarized in this particular table. Mainly it focuses upon the repeat, yes, yes. So after rate, rhythm and axis, we have to see whether the movement is repetitive or not. So repetitive movements are seen in tics and tremors, and these are not seen in Myoclonus, chorea or other forms. Then check whether it is voluntarily suppressible or not, which is seen in case of tics, whereas the other hyperkinetic movements are not voluntarily suppressible. And final S stands for the anatomical site. As mentioned, tics will involve face, neck and vocal cords. Myoclonus will be usually involving limbs. Chorea, mainly distal part of the limbs, which will be break dance kind of appearance will be there. Whereas tremors, it will be mainly involving hands. So hope you have got how to approach when you get a case of movement disorder. Why we have discussed the approach even before discussing each movement disorder in detail, because if we have this clear picture of approach, then we will be easily able to guess the movement disorder. Now we will see each of these hyperkinetic movement disorders. When it comes to tremor, this is the alternating contraction of agonist and antagonist muscles in an oscillating rhythmic manner. So this is the meaning of tremor, but whatever movement disorder you will think about, always try to fit into the same mnemonic, that is rate, rhythm, axis, repeat, yes, yes. So if you try to correlate this one with tremors, when it comes to rate, it is a hyperkinetic movement disorder. When it comes to rhythm, tremor is a rhythmic hyperkinetic movement disorder. Whereas axis will be variable. It is not in the single axis because of the alternative contraction of agonists and antagonists. And is it repetitive movement? Yes. When you see and when you try to show the same movements to someone else, these will be similar. So these are repetitive. And is it suppressible? No. Tremors are not suppressible. And what will be the site of involvement? Commonly, it will involve fingers. Now, once you are sure that it is tremor, what we have to do next is just check whether the tremor is prominent at rest. If it is prominent at rest, we consider it as resting tremors, which is the typical feature seen in Parkinson's disease. And the site which is responsible for this resting tremors is basal ganglia. Suppose tremors are not there at rest, but they are occurring on some actions. For example, when the individual assumes a posture, they are getting tremors. So these are called as postural tremors. The classical example is essential tremor. You might see many individuals when they try to hold some cup and all, they will get tremors. So this is essential tremors. What is the site which is responsible for essential tremor? Mainly excessive sympathetic drive, which is seen in anxiety, nervousness, or hyperthyroidism. So, or because of the abnormality in cerebellothalamic cortical pathways, we might see essential tremors. If it is because of the excessive sympathetic drive, which I have mentioned, usually we call it as physiological tremors. But remember, essential tremors are always pathological because of the abnormality in the cerebellothalamo-cortical axis. And suppose these action tremors are there mainly when they are actively reaching for some objects. So these are called as action tremors, that is kinetic tremor, which is a typical hallmark of cerebellar dysfunction. So if we see at the pacemaker for tremors, it might be basal ganglia leading to resting tremors, it might be cerebellar dysfunction leading to action tremors, or it is due to excessive sympathetic drive with some pathology in the cerebellothalamic cortical pathways, which is responsible for physiological and essential tremors. Then we will see some of the differences between various types of tremors, mainly physiological tremors, essential tremors, and Parkinson's disease resting tremors. If you see the physiological tremors, which are commonly appreciated under stress, and it will be enhanced by anxiety, hyperthyroidism, or some medication, or in some withdrawal conditions due to few medications or alcohol withdrawal, even caffeine intake and all. These might lead to physiological tremors. Usually they will not be present at rest, but the trigger will be after maintaining some posture or during some actions, mainly in the upper extremities. We will be able to see these physiological tremors, and these are considered as high frequency tremors. So the amplitude will be very low. Frequency will be of about 10 to 12 cycles per second. So these are very fine and fast. We will not be able to appreciate many times with naked eyes because of very low amplitude. Whereas when it comes to essential tremors, which are often seen as age-related manifestations, and the exact pacemaker is not known, but it is claimed to involve cerebellothalamic cortical axis, and it will be familial autosomal dominant type of inheritance, in which we see it will get worsened by stress, and many times it might get improved after the intake of alcohol. And these are also not present at rest, but after assuming some posture or during some action, we will be able to see this, and it will be usually bilaterally symmetrical. But when you compare it with physiological tremors, these are of quite lower frequency, that is 6 to 10 Hz, and the amplitude will be quite bigger. That's why we will be able to appreciate it with naked eyes. When it comes to Parkinson's disease tremor, these are resting tremors, and we will be able to see some of the other hallmark features like micrographia, cogwheel rigidity, postural instability, and bradykinesia, and they are prominently seen at rest, and they will disappear on voluntary actions. But here we know where the exact pathology is, that is basal ganglia involving dopaminergic neurons. And these physiological and essential tremors will have excessive adrenergic drive, that is these are mainly beta 2 or beta 1 mediated tremors. So how to manage essential tremors? Step 1 is conservative treatment, that is just reassurance is helpful, and this is indicated when these tremors are not affecting their activities of daily living. Suppose they are interfering with eating, writing, or other activities of daily living, then we have to choose pharmacological intervention, mainly the non-selective beta blockers. Why non-selective? As mentioned, both beta 1 and beta 2 central as well as peripheral adrenergic receptors are involved in the pathogenesis. So using non-selective beta blockers like propranolol will be very helpful. The other therapies which we can choose are neuromodulation using botulinum toxin injections, or some of the other therapies like deep brain stimulation. These can also be tried to suppress essential tremors. Then we will discuss about dystonia. So these are sustained intermittent muscle contractions of antagonist muscles causing abnormal, often repetitive movements or postures. So if you try to fit into the mnemonic, that is rate, rhythm, axis, repeat, yes. So what will be the rate? Here, though it is a hyperkinetic movement disorder, it might appear as slow because of the sustained contraction of the musculature. But still, we will consider it as the exception in hyperkinetic movement disorders. When it comes to rhythm, is it rhythmic? No, these dystonias are not considered as rhythmic. So there is no proper rhythm. But when it comes to axis, these will be sustained contraction of the muscle. So we can say that it will maintain the single axis. Yes, this is the only example we can say. Is it repetitive? These movements are not repetitive. And is it suppressible? Yes, we can voluntarily suppress dystonia to some extent. So these are suppressible. And what will be the site? Commonly it will involve limbs. So always try to fit into this mnemonic so that we will be able to understand the concept better. Now, to see the clinical characteristics of dystonia, mainly what happens is these will be action dystonias. That is, they will be brought out exclusively by voluntary movements. When we ask the individual to do some movements, these dystonias will become prominent and there might be overflow. What does it mean? When we have instructed to do the movement of a particular part of the body, along with the development of dystonia in that segment, there might be involvement of the other parts which we have not instructed to do any movement using that particular part. So this is called as overflow. That is, it can extend to the other muscle groups and body regions which are not required for a given action. And what are the modifiers? Mainly it is aggravated by stress and relieved by relaxation and some sensory tricks. For example, lightly touching the affected body part can suppress dystonia to some extent. The description of dystonia is quite vast, we can say. So whenever we are considering dystonia, description should include these following parameters. Always check for the age of onset of dystonia. For example, if it is infancy onset, childhood onset or adolescence onset, usually these will be due to some genetic cause, whereas early adulthood or late adulthood onset dystonias are due to acquired reasons, mainly some trauma or due to some medications, or there might be stroke leading to late onset dystonias. Then always focus upon the distribution of the dystonia. For example, if they are generalized or multifocal, these are mainly due to genetic causes, whereas if it is due to these particular reasons, it will be usually focal and segmental. This is not the rule, but in this way, if we approach the case, then we might get the exact reason for dystonia and see whether it is static or progressive. Also, whenever we get dystonia, try to find the clinical context. That is, many times dystonia will be the isolated presentation, that is purely dystonia. Sometimes it might be combined with some other manifestations like Parkinsonism or associated with myoclonus, which we call it as combined dystonias. And suppose the dystonia is one of the several manifestations of a disease, we call it as complex dystonias. And the pacemaker for dystonic movements is basal ganglia. And depending on the anatomical site also, we can see varied presentation of dystonia. For example, cervical dystonias might manifest as torticollis or laterocollis, antrocollis, retrocollis, etc. Otherwise, dystonias can manifest as blepharospasm, that is dystonic contraction of eyelids causing repeated blinking. Or there might be oromandibular dystonia affecting lower part of face, lips, tongue or jaw. Sometimes what happens is both of these can come together, especially if you see such repeated blinking of eyes with twitching movements of the face, which mainly involves lower part of face, lips, tongue and jaw. You have to think of Meek syndrome, that is combination of blepharospasm and oromandibular dystonia, particularly in female of more than 60-year age group. Similarly, if the dystonia is affecting vocal cords, it is spasmodic dystonia and it might affect limbs, commonly manifesting as writer's cramp or musician's cramp. You might have noticed these examples of writer cramps many times. For example, this is writer's cramp and these images are suggestive of musician's cramps. These are all the types of dystonias. So overall, in all of these, what is happening is when they are doing voluntary actions for quite a prolonged period of time, that particular muscle group is getting dystonia. So this is the commonest trigger we can say, that is sustained stress to that particular part might lead to the development of dystonias. Then as mentioned, when it is combined with some other manifestations, like many times dystonia associates with Parkinsonism, think of genetic mutations, mainly Sigawa syndrome, and the clue will be they are early onset, that is childhood onset dystonias. Similarly, it can be associated with myoclonus. Again, it will be childhood or adolescence onset. Whereas when it is a part of some syndromes, we call it as complex dystonias. For example, Wilson's disease, Huntington's, Chorea, Lesch-Nyhan syndrome, or some neurometabolic or mitochondrial disorders. So how to treat this dystonia? Mainly, if it is childhood onset, always try with levodopa as the first line treatment, because there is a separate entity called as dopa responsive dystonias, particularly when it is childhood onset, which is also called as Sigawa syndrome. So the first line of choice should be levodopa. Otherwise, for any other forms of dystonias, we can use some oral agents like baclofen, trihexyphenidyl, tetrabenazine, etc. Or the neuromodulatory and the surgical treatment remains same, that is injection of botulinum toxin or deep brain stimulation to that particular area might be helpful. Coming to the next movement disorder, that is chorea, they will be dance-like purposeless movements mainly involving limbs. So again, if you try to fit into the mnemonic, rate, rhythm, axis, repeat, yes, yes. So these are hyperkinetic. Rhythm, it's not a rhythmic movement problem, so definitely it is non-rhythmic. And if you see at the axis, the movement might be in any different axis, so multiple axis we can say. And is it repetitive? No, these movements are not repetitive, so we consider it as non-repetitive. And is it suppressible? Not suppressible. Voluntarily we cannot suppress these, and the sites usually limbs, we can say distal segments mainly. One of the classical example for chorea is Huntington's chorea. So this is autosomal dominant disease which is progressive and fatal. Usually it will be quite early onset. So what happens here is, due to some genetics involvement like mutations in CAG repeats on chromosome number 4. This is the reason, leading to some intracellular inclusions of abnormal proteins like ubiquitin and Huntington. And these abnormal protein inclusions will lead to prominent neuronal loss. So we consider it as a degenerative neurological condition. So what are the sites which might get involved because of the inclusion of these abnormal proteins? It might involve caudate or putamen part of the basal ganglia, leading to these typical choreiform movements. It can also involve brainstem, leading to oculomotor troubles. It might involve frontal cortex, leading to some behavioral abnormalities like aggression, depression, etc. Also, if it involves temporal cortex, there might be prominent psychosis. So just to remember Huntington's chorea, these hunters will seize the animal in cage. So cage, we can remember the CAG repeats, and actually these hunters are having problem in focusing, that is oculomotor, due to involvement of brainstem, and they are not able to hunt due to some motor abnormality, that is movement problem due to involvement of caudate or putamen, leading to choreiform movements. So they are not able to hunt properly. That's why they are getting depression or aggression, psychosis and all. In this way, we can remember everything. And this cage, CAG, if you remember, there are 4 alphabets. So the chromosome number 4 is involved in this. Other secondary causes of chorea are some infections involving again basal ganglia, degenerative disorders, vascular disorders, some metabolic problems like hypo or hyperglycemia. Again, this is one of the commonest cause we can say. Many elderly individuals who are having abnormally high glucose levels of more than 400, 500 and all, they might present with these choreiform movements or even chorioathetosis and all. And if you get the imaging, there might be hyperintensity in the basal ganglia because of the hyperglycemia. And if we correct this metabolic problem, this imaging changes whatever are there will be reversible. And the other causes are autoimmune conditions like Sydenham's chorea seen in acute rheumatic fever, NMDA associated autoimmune encephalitis, SLE, or it might be a paraneoplastic syndrome due to presence of anti-Hu antibodies. So these are some secondary causes which we have to look for. When it comes to Ballism, the definition is violent form of choreiform movements composed of wild, flinging, large amplitude movements of proximal limb muscles, and usually it will be unilateral. That's why often we call it as hemi-ballismus. So as mentioned initially, these are like Arabic dance. Sudden flinging movements of the proximal segments of the limbs can be seen. And again here, try to fit into the mnemonic of this particular chapter. And if you see the pathology, it is mainly due to infarct or hemorrhage in the subthalamic nucleus. So this is the pacemaker we can say. And intervention involves mainly dopamine blocking agents like risperidone, haloperidol, etc. So this is about Ballismus. Coming to Tics and Tourette syndrome, these are brief, rapid, recurrent and seemingly purposeless stereotyped motor contractions, a twitching kind of movements what we see. So if you try to fit into the mnemonic, that is rate, rhythm, axis, repeat, yes, yes. Again the rate is a fast type we can say, that's why it is hyperkinetic, and the rhythm, it is not a rhythmic movement. So It's not maintained. Axis, not maintained again. And is it repetitive? Yes, it is a repetitive movement and it is voluntarily suppressible. And the site commonly involves face or vocal cords. So what might be the different manifestations? We call it as simple tics when it manifests as blinking movements, nose twitching or neck jerking movements. Or sometimes it might be complex tics where the individual might have repetitive jumping, sniffing, head banging, echopraxia, that is mimicking some movements. So all these might be the manifestations. Or it might be phonic tics which might present as simple grunting or echolalia. So these kids usually will be repeating the words what they hear. Or it might be palilalia or coprolalia, where these kids will be speaking with some abusive words, that is coprolalia. And it might manifest as sensory tics where the individual will be feeling unpleasant focal sensation in the head, neck or face. And there is a typical tic cycle which we will see in many individuals. So what happens is when they express this tic, there will be temporary relief. Then again they might start having the urge of these twitching movements, but they will try to voluntarily suppress it. But this suppression will build internal tension. Then there might be irresistible urge leading to the expression of tics again. So this is the tic cycle we can say. What is Tourette's syndrome? It is a type of tics disorder where because of some unknown genetic mutations, it might manifest as multiple motor and phonic tics. Usually the age of onset will be 2 to 15 years and often it will wane off as the age advances. But if these movements are interfering with the quality of life, we can treat with atypical antipsychotics, tetrabenazine or Botox injections, even deep brain stimulation. Coming to myoclonus, these are brief, rapid, jerky movements of single muscle discharge or repetitive discharges. And unlike tics, myoclonus is not repetitive and it is not suppressible. And there is no premonitory urge which we commonly see in tics. The phenotypes of myoclonus are action associated, where these will be prominent during some voluntary movement, or they might be just reflex myoclonus in response to some external stimulus. The other phenotype is negative myoclonus, that is brief loss of muscle activity. Commonly we see this one as asterexis in hepatic encephalopathy, respiratory failure and all, which we also call as flapping tremors, where when we ask the individual to maintain a sustained posture, the signals to maintain that posture which are getting relayed in the brain might be interfered with the toxins which are accumulated due to liver pathology or due to excessive carbon dioxide in respiratory failure. So they will interfere with the relay of these information. That's why the individual will not be able to maintain the posture, leading to loss of posture in between. That's why we will be able to see these flapping tremors or asterexis. And we have to remember that it is a form of negative myoclonus. Whereas the other form might be hypnagogic, that is jerks observed in normal individuals while falling asleep. And what is the pacemaker for myoclonic movements? These are due to abnormal discharges in cortex, subcortical area, brainstem, even spinal cord regions. Only thing we have to remember is these can progress to myoclonic seizures as well. And these are commonly seen in adult, college-going adults, where there might be sudden involuntary jerky movements of the limbs. And what is the treatment for it? GABAergic medications like valproate, levetiracetam, clonazepam or primidone can be utilized. The other movement disorder is restless leg syndrome, where there will be unpleasant sensation in the legs, triggering an overwhelming urge to move legs. Often the symptoms onset or worsening will be seen at rest, and they will peak during evening or night hours, leading to severe sleep disturbances and daytime sleepiness. And for diagnosis, we can take the help of polysomnography, and as treatment, dopamine agonists like pramipexole, ropinirole can be utilized. And finally, coming to drug-induced movement disorders, mainly here we can look for the timeline after the initiation of medications. For example, some movement disorders can occur within hours or days of starting the medication, which we call it as acute drug-induced movement disorders. And it might present as dystonias. And in some cases, it might be subacute, that is developing after days to weeks of initiation of medication. And it can present as akathisia, that is intense restlessness, where the individual will have overwhelming drive to move around. Sometimes it might be a very delayed onset drug-induced movement problem, that is chronic after months to years. That's why it is named as tardive. Tardive means delayed dyskinesias. It might be manifesting as coriform movements or dystonic movements. What are the common drugs which are responsible for this drug-induced movement disorder? Mainly neuroleptic drugs which will block the dopamine receptors. Some antiemetics like prochlorperazine, metoclopramide, and even The other prokinetic medication, that is levosulfide, can also be responsible. And how to treat this drug-induced movement disorder? Try to find out the culprit agent and avoid that. Also, we can take the help of anticholinergics, dopamine agonists, beta blockers, or tetrabenazine. So this was in-depth discussion regarding movement disorders. Hope you have understood the approach and the mnemonic which you should apply whenever you get the case of movement disorder. That is rate, rhythm, axis, repeat, yes, yes. If you have any doubts, put it in the comment section. Thank you so much.